Good afternoon, Ireland and around the world from London. I am delighted to be with you today. My name is Susan Hopkins and I'm an infectious diseases clinician and epidemiologist. And I'm here today to talk to you about point of care tests and particularly lateral flow tests in helping us manage the pandemic of COVID-19. Based in London, having trained for many years in Ireland and become a fellow of the Royal College of Physicians of Ireland almost 15 years ago. So I'm delighted to talk to you today about our journey of point of care tests for COVID-19. And I will try and describe the journey that we've been on over the last year and some of the investigations and studies that we have looked at to assess their suitability in COVID-19. So as many of you know now, but we didn't have any knowledge of at the start of 2020, about 1 in 3 people with SARS-CoV-2 never develop symptoms. And the idea very back early 2020 was that if we could do asymptomatic testing at scale, it might allow us to find more people with transmissible virus and help control outbreaks. And this is not unusual. We've used this for other settings, potentially for looking at respiratory diseases in healthcare settings or social care settings. We often look at it when we're trying to detect cases of measles in endemic settings. And we, of course, frequently look to do it for tuberculosis, where we try and find latent or asymptomatic disease. But of course, for many of those, the incubation period is longer or the diagnostic tests are more available, and therefore it is easier to make the diagnosis of alternative conditions. There was lots of modeling data that was coming through showing that if you repeatedly tested in either the community or in special settings, you had the potential to break the chains of transmission. And this, what I'm showing you here is a graph from Mina et al. From the New England Journal of Medicine, which has been modified to slightly show you some of the additional testing diagnostics that you could use. And this is a typical curve for an individual who has a rising amount of virus for COVID-19, and over many days it starts to wane. And what we know is that actually now that people are infectious from 2 to 3 days before the onset of symptoms, if they're going to develop symptoms at all, and they then have high amounts of virus for a number of days after that. And it's different in each individual, but on average, people are highly infectious for about 7 days, though there is a tail in some individuals. But one of the challenges we have is the PCR tests that we use detect the RNA rather than the antigen. So parts of the viral RNA that could actually be at the dead or dying stage. And therefore, we also know that people who can actually have virus detectable through PCR tests for many days and weeks and even months for some individuals. Lateral flow test, which is what we've particularly focused on, detects antigen. And therefore, it will really only detect it when you've got intact virions and for much shorter periods of time. So we think that you can detect the virus, and we've shown that you can detect virus antigen from about day -2 to about day +4, but that you can detect the from PCR from probably day -3 to up to day +20. PCR, of course, doesn't measure infectiousness because at many points at the end of that journey, you are no longer infectious as you've cleared the main antigen that would cause infection to others. And also you will have an antibody that's bound to the antigen at the back of your throat. PCR also requires specialist equipment, staff, logistics and laboratories in order to be enabled to do it. And even with point of care tests, they're quite expensive in order to be able to do all of that work in point of care testing machines for PCR. And even in the best point of care testing machines, it still takes hours, usually a minimum of 90 minutes to 2 hours. But if you have to send it to a laboratory, it's much more likely to be at least 24 hours and even longer if you have to travel further. Antigen tests, of course, can release the results in minutes. Positive tests can come up positive within the first 5 to 10 minutes after doing the test. And for the vast majority of them, you give it a definitive result by 30 minutes. And of course, with all of these things, PCR is much more costly than antigen tests. So what was the problem that we were trying to address? Well, we were trying to address the fact that in 2020, we were only detecting probably 1/3 of infected individuals through PCR testing. We needed to identify infectious individuals who transmitted, and that needed to look at both pre and asymptomatic, with a quick and easy test that was cheap and repeatable and gave a rapid result, and to isolate of those individuals to prevent spread. And of course, this was particularly important in areas where you could have high amounts of transmission, such as hospitals or adult social care settings, but also potentially in areas like schools as well. But in 2020, we didn't have lateral flow tests. So what we all did at some point in 2020 and at many points in 2020 was go through regional and national lockdowns. And that's, potentially reasonable in areas of high prevalence, especially if you've got a prevalence of 3% or above, and in order to protect our hospitals and healthcare systems. But if you've got down to lower prevalence, 1% or less, we are asking 100 people to isolate to protect, to prevent one potential episode of transmission. In looking at self-isolation in those individuals who have a self-diagnosis with symptoms, what we know is that those, at least when COVID is prevalent as it is in many countries right now, about 10% of those with one of the main symptoms, cough, fever, loss of sense of taste or smell, about 1 in 10 of those will go on to be PCR positives. So we're still asking 10 people to isolate for only one positive result. Of course, many of us have now grown our PCR capacity, so anyone with symptoms has the ability to get a PCR test. But even for other individuals who are quarantining either pre-vaccination, post-vaccination or post-travel, we're still in those individuals asking very many people to isolate who do not need to isolate and will never be infectious to others. And that's very different to those that are PCR positive, because if you're PCR positive at any point in time, about half of those people are likely to transmit. Now, very much more likely in the early stages. Of course, you may have missed that, and very less likely in the later stages. And we're not the only people who were looking at this. There was a letter from a number of leading scientists who wrote to the ministers in the UK about this, and also wrote a letter to the Lancet. And of course, we saw China and many other countries look at ways to test the entire population to try and detect the asymptomatic cases. This was just some of the modelling, and we had many different groups looking at modelling for this for us. But this, I think, nicely shows us what you could detect if you did repeatedly use tests. And this here looked at a lateral flow device with a sensitivity of 65%. And we looked at an individual who was likely to have infection for an average of 5 days, with a couple of days standard deviation around that point of time. And that about 50% of people developed symptoms. And what you can see here is that if using lateral flow tests every 2 days with 100% compliance in their use, you would detect 80%, or you would reduce the infection risk across groups by at least 80%. Of course, if you only had a 25% compliance in doing those tests, that would be much reduced. And if you use tests every 4 days, that would reduce the infection potential by about 60%. So there's a sweet spot in trying to get people to do tests frequently enough in order to be able to remove infectious cases from the population and in order to continue to do those tests. And for the majority of the policies we developed, we tried to do something simple like twice a week, which is somewhere between 2 and 4 days, in order to recognize that we are reducing the infection potential, but not eliminating it in the population. Of course, compliance is really important. If people don't test, that really reduces your effectiveness on this. And of course, the more frequently you ask people to test, the probability is that the less compliant they would be. And therefore, this was our idea when we started to introduce and look at the policies of testing twice a week, rather than testing on a daily basis. So last July, with the starting of lateral flow devices coming to the market, we decided to set up a formal evaluation process with what was then Public Health England, now the UK Health Security Agency, and Oxford University, in order to look and identify the pipeline of products coming through and to determine whether in our hands, whether they were effective tests. And as many of you who may have looked at these tests are aware, the instructions for use and the packaging often declare that these tests were a sensitivity of 100% and a specificity of 100% or close to. but they were often done in very idealized settings and not the settings that we would want to do them in. So that we did futility tests looking to see whether they would actually detect the coronavirus, and then lab-based and field-based validation. And I'll go through some of those results that we found from the first few tests as we go through. But just to highlight, we have now looked at more than 500 products. We've had 168 tests completed futility testing, a further 60 tests that have completed full 3A testing, which is clinical sensitivity and specificity with real life samples. All of the tests that have passed are available on our website. We have then proceeded to full community research programs, and 4 products have had full clinical studies. For many of the others with exactly the same parameters, we now do testing to ensure that they're easy to use rather than doing full clinical studies for those tests, as long as they have the same parameters as the others. And you can see the 40 lateral flow devices compared here. And in commissioning and looking at new tests that we develop, we look at their sensitivity and specificity that we have seen in our tests in our labs in order to procure those for use in our population. So let's go back to some basics. So what we first did was we look and see whether what level of a virus we could detect these assays with. And we do that by looking at live virus, which we quantify and know exactly what that looks like with plaque forming units, and that we have a marker to determine what that CT value, the cycle threshold value for PCR tests would be. And you can see at high virus levels, you can detect it a lot. And at low virus levels, you can detect much less. Now, the issue, of course, here is that plaque-forming units are live virus, and many people with high levels of a viral load may actually have dead virus as well in their throat or nose. So what we did also was looking at the real-life testing of those attending test sites. So these are mainly symptomatic individuals or contacts of symptomatic cases. And what you can see here is, again, very similar results to actually what we found in the laboratory. And you can see that in the individuals with very high viral loads, we detect well over 95% of cases. And as you have lower and lower viral loads, then you are much less likely to detect cases. And so we think that the optimal cutoff for virus is probably with a CT level comparable of 25 to 28. And below that, it's a much less robust test. So high amounts of virus, good, low amounts of virus, not very good. And again, we went on to look at this in a number of different field studies, and the majority of field studies came out in a similar way. And what we also found is that there was some evidence that in the first or second time you use these tests, you were less likely to be able to detect the faint positive band, but the more you use the test, the better it was. And we also looked at false positives and specificity in the field in a variety of different settings. And again, what we saw in that stage was that actually, first of all, when you go out to people, they're more unsure at the beginning. So the phase 4 for the inexperienced staff were less likely to read it effectively. And so it showed that it was important to train people and to look at that as an important component to get reliable results. And we also were very keen to know what was the difference between a self-test versus doing it on site with somebody else doing the test and reporting the test for you. And you can see that we did a number of self-tests at home for individuals and tests in our testing sites across the country. And actually very, very similar testing results were observed, so that we don't see a dramatic difference in positivity between self-test at home and asymptomatic test sites. So this is a test that can reliably be delivered in the home environment. So where has this been used and how have we used this? Well, one of the big challenges that we all have had is transmission in the healthcare environment, particularly in hospitals, often from healthcare workers to healthcare workers. And we have shown that very nicely in some of our studies that we've done with outbreak investigations from genomics, but also in looking at the contribution to the transmission in hospitals in particular. So we had an ambition that we would like to test everyone with PCR tests every week, but we have 2 million health and social care workers in this country, and that is an awful lot of asymptomatic testing to be delivering from PCR tests. So as we had validated our first test, which was our ANOVA test, we decided we would roll this out within the healthcare setting. We had a subset of healthcare workers that were contributing to another study I lead called Siren, where we do alternate week PCR tests. So we were able to validate in real life the LFDs and PCR tests in these cohorts. And what you can see is that we started in secondary care in November, primary care in December, and then to private providers who deliver our public NHS services by a commissioned route in January. And you can see what we detected. Almost 60,000 cases in secondary care have been detected so far, with the largest amount of detections just as vaccination program and the alpha wave was taking off. And you can see that with the continued use of these tests and vaccination as well, of course, while we see subsequent waves of infection as part of the Delta waves that we're seeing, nothing at all like we see in the community. And this has been a very effective measure at reducing transmission in hospital settings. The other big area that we were interested in schools, and like you, we had many closures of our schools, and we were very concerned from a wider societal and public health point of view in our children's education and ensuring that they got back to school in a safe and effective way. So on March the 8th last year, we reintroduced school testing and brought everyone back into the school environment. And what you can see here again is that we started testing staff and individuals who were attending schools because of their parents being an essential worker or they requiring extra care in school from January, but that our large, massive surge in testing in secondary schools took place in March as people returned to school. And what you can see is that in the return to schools, we really were able to detect lots of cases and effectively reduce transmission in schools over the summer term. We also had a big push to get schools to retest in the beginning of September. And you can see that is a much smaller size of individuals who did that at that point. But it did hold the first couple of weeks of return to school steady. As children then reduced their testing frequency, we started to see more cases and outbreaks over time. We also, of course, were very concerned that with new variants such as Delta, that we wouldn't detect cases. But you can see in our laboratory testing on the left that we were able to detect cases very well with a variety of different testing tests that we were using at the time. And that when we looked at the first area of the country, so this is Bolton, which was our first area that had a large outbreak with Delta, we actually were able to use the lateral flows to detect these cases in school-age children in our summer term. So very reassuring use of the lateral flows in this population. And we have an ongoing monitoring program which looks at all of the different variants through genome sequencing and which of these individuals were detected by lateral flow tests. And again, we are continuing to see through all the variants and subvariants of Delta that we can detect these through lateral flow tests. So that was our sort of starting point. So we've now got to a point where our schools, our hospitals, our social care settings, and many members of the public use lateral flow tests regularly to reduce transmission to others. But could we go further? Coming back to the point that we had many children who were off school isolating because there was a case in your class, and I'm sure many of you here today have had moments where you've had to stay at home because your child has been in a class with another case. So here we wanted to test in a cluster randomized way whether it was safe to use daily testing in schools as an alternative approach to sending children home to isolate if there was a case in the classroom. And we first of all did some modeling which suggested that serial daily testing, so daily testing every day for 7 days, was going to be as effective as isolating year groups and potentially as good as testing twice a week and isolating individuals as well. We randomized 201 schools, half and half to the control and intervention arm. The control arm had standard of care, so children were asked to go home and do PCR tests if there was a case detected in their close proximity or in their bubble. And in the other group, children were actively promoted to come to school and do daily tests, daily lateral flow tests, if they were positive. Of course, some schools did not want to participate when there was an outbreak or a cluster in the classroom, and parents obviously had the ability to decline their child coming to school in this scenario. But nonetheless, we had excellent participation from school and staff in the study trial. So here you can see the overall wave of infection that we saw, and I think it's important to recognize that for both the students and staff, both the intervention and the control arms very much mapped the community rate. So as you can see, the more infections in the community, the more infections that we see in students and staff. And of course, this was even more likely because these are the age groups that had not yet received vaccination. Many of the teachers were younger, and of course, the students were not being vaccinated at this time. And again, what you can see is in the control arm that there were 55,000 related absences, and 3.1 million person school days. And in the intervention arm, there were 48,500 absences during 3.3 person school days. So what you can see here is that overarchingly, there was no difference in the groups who would either develop an asymptomatic infection or a symptomatic infection in the rest of the class groups who went on to develop symptoms and to have a test or be detected through the twice weekly lateral flow tests, showing that this was a reasonably good alternative to sending children home. Of course, with all of the vaccination, we were worried that we didn't need these anymore. These were just something that were important at a point in time. But as many of you will know, that despite a vaccination program that has happened very well across the world, and particularly across Europe and North America, where the vast majority of adults have now had their vaccination program administered, and a very high uptake in large amounts of age groups. What we are still seeing is rising numbers of cases in many age groups, slower than before, and of course less of an outcome of severity with reduced hospitalizations and deaths, but nonetheless many cases in the community. So here we did a very large study where we looked at all of the data coming into our lighthouse labs, so our community tests, which is about 500,000 tests a day. And we looked at all individuals who were a contact of a case and who had to test, and we are able to link all of that to our national system and also to our vaccination records. And you can see quite clearly our alpha wave declining in April, May, and our delta wave surging. And we adjusted this analysis for the usual demographic indicators and also calendar time as a proxy for changes in behavior or vaccination status. And what you can see here is that to Delta, similar levels of unvaccinated index cases by 12 weeks post the second dose for the AstraZeneca vaccine, and also similar reductions in the level of cases in Pfizer. So really big challenges that actually even with the vaccination, we are seeing higher levels of case rates with the Delta wave than we saw previously with Alpha. And the numbers are here. The odds ratio, or the vaccine effectiveness to transmission, has reduced by approximately a third in both groups. But of course, then we had the final question was, well, perhaps that's true, but we perhaps have slightly less viral load post-vaccination. And we have now got increasing evidence that the viral load, if you get an infection with Delta, doesn't change that much, even if you've been vaccinated. But what we wanted to do was check that if we looked at LFDs post-vaccination and pre-vaccination and partially vaccinated, did they work as well? And we can see absolutely no difference if individuals have got any symptoms at all. If you don't have symptoms, then potentially there is a small decrease in those individuals who have been vaccinated either partially just after their second dose or fully vaccinated 2 weeks after their second dose, where you reduce the sensitivity from potentially 50 to 40 to 45%, but still substantially able to detect large amounts of cases. So where to and what have I gone through? So we've looked at multiple lateral flow tests, and they've gone through a robust laboratory and clinical evaluation framework. They are a reliable test with very well characterized performance at this point. They're able to detect high levels of viral load and most likely to transmit to others. We've detected over 100,000 tests in health and social care since the start of the programme. And currently, about 1/3 of all cases we detect a day are first detected on lateral flow tests. These are cases that we would not have been able to detect easily prior to December 2020. We have a cluster randomized trial that showed that it was non-inferior to isolation in schools for school contacts. And we also have an individual trial, which I haven't shown you data today, which will be released in the next couple of weeks, looking at community contacts, both household and non-household, as an alternative to isolation. In Delta wave, the vaccination has reduced but has not eliminated transmission, and the LFDs still work after vaccination. So while these are not a magic bullet, they are another tool to help reduce transmission, get our lives back to normal, detect asymptomatic and pre-symptomatic cases in our population, and help us prevent further restrictions to our way of life as we move through this winter into the endemic disease that COVID-19 will become. One of the final challenges is how do we influence manufacturers to look at other point-of-care tests, and are there other point-of-care tests that would be effective in our management of infectious diseases in the future? Thank you very much.